start my slide? Excuse me. Yes. Thank you for your kind introduction. And also, first of all, I'd like to thank you, the organizing committee, especially Dr. Lu and Dr. Luan, for inviting me to this wonderful conference. And also, I'm very pleased to be my good friends here today. This morning, I'd like to talk about optimizing liver ablation, practical tips for enhanced efficacy and safety. As we all know, ablation is recognized one of the curative treatment options for early stage HCC in most treatment guidelines. To maximize the therapeutic efficacy, we need to do the novel technology, inclusion, precision, and AI-assist technology. However, we should remember basic must come first. Fundamental tips for achieving complete ablation and essential tips to avoid complication is important. These fundamental techniques are not thoroughly understood. The most novel advancement may fail to secure the long-term growth of ablation as a curative option. 20 years ago, we tried to make the consensus on standardization in terminology. However, technical standardization is still a long way to go. Last year, Korean Liver Cancer Association published a document, local ablation consensus, including patient selection, treatment imaging, and preparation, and performing ablation, and follow-up strategies. And also, Asian Society of Tumor Ablation recently published ablation guideline, including indication and imaging and techniques. You can check in this article. As we all know, we have too many weapons for local ablation therapy. Which one is best? This is a really long-standing question in every conference, but unfortunately, we don't have any clear answer. So I think it's time to move our question to how to use in a right way. As we all know, many experts expected microwave ablation would replace RFA from 20 years ago, but still, RFA is still alive. Because at the moment, most studies fail to prove real benefit of survival of microwave ablation over radiofrequency ablation. Prospective randomized studies becoming challenging, especially when the therapeutic effects are seen like microwave or RFA. The rate of local treatment application over survival very significantly across institutions, which means we need standardization. Many factors influence treatment outcomes, making it all more important to interpret and apply with caution. And also we need greater consensus on procedural standards, as well as enriched training and dissemination of technology. And beyond just focusing, expanding the indication, we need to focus on optimization for existing local regional treatment. As we all know, the devil is in the details. So it's time to dive into our past. Shall we dive in together? Successful local treatment can be defined as one that ensures the adequate ablative margin margin while minimizing both complication and mortality. So to balance between complete and safe ablation is really important, as we all know. Moving on complete ablation. For complete ablation, we should consider three factors. First, careful selection. Second, precise planning. Third, accurate ablation. Careful selection. Achieving effective ablation begins with careful evaluation of whether the tumor meets criteria for optimal treatment. Please think in 3D beyond 2D, especially for tumor. 5 to 10 millimeter oblique margin in ablation zone is essential to minimize local recurrence because of microsatellite nodule surrounding the tumor. Selecting tumors that can be completely ablated with the available energy source is important. If the tumor is too large or has a non-distinct boundaries, achieving adequate ablation margin becomes challenging. If microvascular invasion or imaging is suspected, local ablation alone may not be sufficient for curative treatment. In such cases, multimodal approach incorporating resection or paced therapy may be more appropriate. Again, careful selection of good candidate is critical. This is the first goal for successful ablation. Please carefully select the enemy that you can clearly kill with a single sheet. Moving on, precise planning. Meticulous pre-procedural planning is essential. We cannot build this kind of gorgeous building without the detailed planning. The selection of energy source, type of applicator, and optimal placement strategy must be carefully determined. Specifically decide all the details at the planning phase. Well-structured plan significantly improve treatment outcomes compared to unplanned reactive approach during the procedure. Please remember there are two intrinsic pitfalls of ablation. First, no device will provide spherical ablation volume. Second, our applicator path is not always parallel to the longest axis. Always consider whether accurate placement of any applicator can be possible along the largest axis of the image tumor. This is really key. If you are sure yes, you can use just a single electrode, either RF or microwave, depending on the largest diameter of the tumor. But our reality like this. So if you are not sure, please consider multiple applicator would be better to guarantee the circumferential ablative margin. We have to stop overlapping ablation with a single applicator when you cannot be sure of exact central puncture along the largest axis. No more overlapping ablation with single applicator. Moving on accurate placement. Successful ablation depends on the accurate applicator positioning. Conspicuity always matter. So we need to consider enhance the conspicuity of tumor ultrasound. First, solid window optimization, position change, or use of artificial situs or pleural fusion. And tumor conspicuity enhancement using the fusion and contrast lens ultrasound. Punctual placement is really critical. Take your time for really acute placement. Moving on safe ablation. For safe ablation, first we should know the broad spectrum of complication. Second, we need to prevent, and we need early detection and proper management to avoid mortality. There are so many spectrum of complication after ablation, from bleeding to severe. And we have to prevent first and detect earlier as much as we can, and we have to properly manage. So, if so, how are you doing? So this is my recipe, current recipe for routine procedure. As we all know, tumor size, location, and conspicuity is really important for successful ablation. Recently, I recognized that tumor exit is also very important. All factors are satisfied, I just do single microwave ablation. If any category, the answer is no, so at that time, I use multiple RF electrode. So I prepare two cases. This is a single ablation using the microwave applicator. There is a conspicuous tumor with exit in safe location. In that case, I use a single applicator through the central core of the electrode, and then monitor using the fusion imaging software, so-called centrifugal ablation. It's pretty nice, just 4 or 5 minutes. There is no bleeding, actually almost no one, most minimal invasive approach. Pre-ablation MR and post-ablation CT. They consider the tissue contraction of microwave ablation quite successful. Second case is a 3 tumor with the inconspicuous and no exit tumor. That's why I used multiple RF electrode, so-called no-touch technique. The first electrode inserted at the third electrode, lateral superior marginal tumor. Because the tumor was inconspicuous, start ablation from the posterior margin and anterior margin, finally lateral margin. I was quite sure ablating margin was another, so-called centripetal hemangioma-like ablation. The second tumor is also, there is no exit because this tumor is a high application, then there's a posterior parenchyma is not enough. Also dangerous structure. That's why I don't use the single microwave ablation. Again, just 7 or 8 minutes, you can get the superficial ablating margin. Finally, subcapsular tumor, sticky tumor. I just use the 2 electrode and then ablate for 3 minutes. Really minimally invasive compared to laparoscopy approach. First ablation zone and third ablation zone. So ablation is well positioned in curative treatment option. So it is time to optimization. But compared to solo performance, I think, as you all know, orchestra is better. Harmony is really key beyond optimization. I mean, the multi-disciplinary approach is the really smart key to achieve the best result of our patient with HCC. This is our center study. You can see MBT cases shows better survival.
Thank you so much. Excellent topic about ablation and liver tumor. By the way, how many years have you done ablation for the patient?
Yeah, I started, I learned ablation in 1997 in the United States, and I introduced 1999, so 25 or 6 years.
Thank you. That's why. So, are there any questions from the audience? Or some comment? Okay, please.
Thank you for the wonderful and very calm, relaxing presentation. I just want to ask your opinion about the comparing to ablation and histotripsy. Do you have any idea what is it to be if the histotripsy is more popular or something like that?
A very good question. I also have a similar question for 10 years, but at the moment I don't have the good answer to you. The one thing is that histotripsy is promising, but which one is better frame? Maybe 10 years later, I guess histotripsy is one of the similar, I guess in my opinion. Has a lot of advantage, but even microwave ablation has a lot of advantage. Short ablation, quick and big ablation joint. But 10 years later, finally, there was no survival gain. I think there was no survival gain. I think the other 5 minutes saved, for example, microwave is not so much important. That's why I think we should study more on histotripsy, so we will see maybe 10 years later.
Okay, thank you very much. Now we have to move to the next speaker from the United States.